are coming slowly. So if you look at the neurological burden in NBC, the crisis of survival without recovery is quite bad. But new cases annually are about 12.2 million, and there is a neurologist gap of nearly 82%. These are the leading neurological conditions which requires the rehabilitation. I am particularly heading the Lancet Commission of Neurorehabilitation in epilepsy and CNS infection, and I are going to present the data in next half an hour after this lecture at Lancet Commission to present what has been a big gap in neurorehab in epilepsy, which many of our colleagues from working in epilepsy would be able to tell. But there's a lot of work to be done, but there are paradox of medical progress. What we have achieved is improved acute survival either from stroke, TBI, or other neurological emergency through advances in medicine like tenecteplase and in, mechanical thrombectomy, neurosurgery, critical care. But what remain unfinished is survival without recovery means million lives with preventable disability. Without rehabilitation, the person who survived a stroke may never walk again, or the child with CP may never attend the school. Survival is necessary, but it's not sufficient. This is what we need to work on. So why neurorehabilitation matters? From mortality reduction to disability management and toward full participation. And that's what we are looking at is beyond mortality to the meaningful life. The economics and human case for rehabilitation, if you look at global economical impact is nearly 890 billions, and which is a global stroke cost, which is 0.66% of global GDP annually, an enormous, largely preventable economic drain. So this is what politicians need to understand to work more on that. And home-based rehab program demonstrates 61 to 67% likelihood of cost effectiveness with significant higher quality of life gain improved compared to the no rehabilitation. These are latest data. So WHO Rehabilitation 2030, we are an active member at WRA, IFNR has been working on that. It's essential for universal health coverage, and Government of India is also committed to provide rehabilitation to 2030 as per WHO. So what rehabilitation determine is whether a stroke survival walks again, whether a child with CP attend school, whether a person with epilepsy hold employment, or whether survival translate into a productive, dignified life. The current reality is fragmented system, missing workforce, and 2% access to rehabilitation, just 2% access to rehabilitation. And I'm particularly really pleased this time to see that many of the neurologists are here to understand the rehabilitation and take it forward. So that's a change what I've seen in last 10 years in India. So there is an urban-rural divide, limited interdisciplinary care, poor care continuity, and lack of standardized protocol. And this is our responsibility to produce the standardized protocol in this country. So workforce shortage across the discipline. So there are, if you look at this, 32.7% of the WHO standard, a critical deficiency in neurologists. The physiatrists, only 5%. The physiotherapist is 15%, OT is 8%, speech therapy is 4%, and neuropsychologist 1%. So inconsistent criteria, limited clinical exposure, inadequate supervision, and lack of competency-based assessment plague the neuro rehab trailing across the Asian Oceanian country. And this is what is a challenge. So what we are going to define is competency in neuro rehabilitation, and WHO rehabilitation competency framework is something which is through the RCF now provides a structure internationally validated foundation for defining what neuro rehab professional must know, do, and embodies. That means practice, professionalism, learning and development, and management and leadership. These are the 4 points which we need to follow uniformly. But there are key competency gap and Asian Oceanian lens, if you look at, one is training variability, the inconsistent curricula across countries, physiotherapy program, 3 to 5 years with neuro rehab content spanning only 8 hours to 6 months. So that's not much. Limited complex case exposure, even in neurological curriculum, neuro rehabilitation is not being taught even during the DM. uh, Weak acute rehab integration. So, during acute care, many times the rehabilitation is not yet started. It's only start after the discharge or just before the discharge. The technology competence gap. The interdisciplinary collaboration is lacking and the community-based rehabilitation is there but not uniform all across. So these gaps are not individual failures, they reflect a systemic inadequacy in training infrastructure, uh, faculty capacity and curriculum design across the region. We have Dr. Damija who has worked quite a lot on the through the brain health, and I'm sure he will, appreciate the deficiency what we have noticed. So, what are the challenges which are unique to LMIC? It is beyond training, systemic barriers. So there is a resource constraint, which we all know. There is a late referral. There is a geographical barrier because of rural patient travel a large number, a long distance, and family disruption. So caregiver burden is something, and training, which is completely lacking in our part. Of course, there are financial barrier and social stigma, which is no mental health treatment in 70% of patients. People, no treatment whatsoever. Stigma is a major driver, so they don't even go to the therapy. So these are some of the barrier which we have to overcome. But there is an opportunity in the region because this Asian country have a strength. And what is the strength is a strong family support. So, you can use the family-based or community-based rehabilitation to train them, and co-giver can act as a co-therapist, which is a powerful, cost-effective solution. And we need to take advantage of our family system and digital health information. The India, China, Asia has really transformed the low-cost digital technology. Even in the rural area now, people are able to use that. The growing academic institutions across the Asian Oceanian region is another opportunity. And now that government interest because of there's an increasing policy attention to rehabilitation and disability inclusion, largely because of WHO Rehabilitation 2030 docs. What are the mobile opportunity? 5 billion smartphone user globally. And Asia leads in mobile adoption, as I mentioned to that. So these mobile-enabled rehabilitation applications are something which we really need to develop and take it forward. They can be app-based exercise prescription, caregiver training through video, remote monitoring of patient progress, and low bandwidth teleconsultation and specialist supervision. IFNR has working with Manstik. We have developed some app application, low cost for the dementia, and those who are IFNR member could get those access to the platform. They can visit the IFNR stall to get 1 year free access because of our collaboration with Manstik. So that's something which we have done, and I'm sure you all would like to take advantage of that. Model that work through the evidence from Asian Oceanian region is promising model have demonstrated that effective neurorehabilitation is achievable even within severe resource constraint. And these are not pilot projects, they are scalable solutions like family and community-based rehabilitation, tele-rehabilitation, task shifting models, and public-private partnership. And these are something which we should be proud of. India's Kavi model, a blueprint for LMIC neuro rehab at scale. It is a Karnataka brain health initiation. Madam is right there sitting along with Ida, who has developed this. And the first state-funded LMIC program, which is combining district multidisciplinary clinic, caregiver-assisted home exercise program, and structured tele follow-up, a model designed for resource constraint setting. 33 brain health center and 70% improve. I can't give better than you, madam. You have been doing it, but this is something which is a core model competent for district multidisciplinary clinic caregiver assistance. So this model demonstrates that state level policy commitment combined with task specific shifting and technology can dramatically expand the access, and all other states should follow this model, and I'm sure you would be able to convince the people to take this forward. Technology as an enabler, promise and pragmatic for LMIC. The tele-rehab platforms are to be synchronous because asynchronous store and forward video-based exercise review reduce the bandwidth requirement. So this is something we can do. We have good engineers and IIT guys who are part of IFNR, and they would be able to help us out. Wearable sensors, something which is coming big way, AI-assisted assessment and smartphone applications. Malaysian team, Yeti and others, they have been doing a lot of work on tele-rehabilitation and low-cost tele-rehab, and they've got a lot of paper. So low-cost focus is something which we have to work, low bandwidth with offline functioning and SMS backup, which is what Dr. Volker always talk, that we need to work on low bandwidth, designed for caregiver operation, not just clinician, is something we need to look at. So we need to build competency and education and training framework through the competency-based curricula, which is not uniform again in our Asian region, stimulation and skill labs, simulation and skill labs and continuous professional development, which should continue, and regional collaboration. This is where we need to work together. And I am particularly happy that as a president of Asian Oceanian Society of Neuro Rehab, I'm trying to work out to have collaboration with various countries, which has been in some way has been working. So evidence-based demonstrate that 13 of 15 competency shows significant improvement with RCF-based training program, validating this framework as the cornerstone of neuro rehab workforce development across Asia and other Oceanian region. So competency-based curricula, WHO, RCF aligned design for both undergraduate as well as for postgrad, simulation and skill development, safe practice environment, and continuous professional development through short courses, online modules, webinars, remote teaching. And we all have been doing it not only in India, but completely through the AOSNR. And for last 2 years, we have been following that. The regional collaboration for excellence is important, and the faculty exchange program, which IFNR has been doing with various countries like Malaysia, Azerbaijan, and Tashkent. So we have been doing regularly, not only that, but also in the SAARC region like Bangladesh, Nepal, and Sri Lanka. Standardizing the regional guideline is something which is need of hour, and we need to work together to come down to these clinical practice guideline. And the Korean team is very strong in various advancement, and we have been always taking help of them to take us forward in the robotic and advanced system. Both Won-sik and his boss, Nam Jong-paik, president-elect of WFNR, has been very kind to guide us in this particular segment. Policies and system, creating enabling environment, integration into the primary care, national rehabilitation policy, and I'm sure Dr. Tamija is going to help us out to reach out to the policymakers, and he's sitting in right capital of India, so it will be easy. Insurance and funding model is what is we need, is a burning issue, and we really need to hit hard to get insurance coverage for all our patients, at least for 6 months to 1 year post neurological insult. And regulatory framework are something which is very, very important. Licensing, registration, a proper therapy protocol, because we just don't want everybody to inject the stem cell for any damn condition and, without any regulations. The intersectoral imperative is what rehabilitation require, coordinates across health, social welfare, education, labor ministry, which is, the approach which fails through the integrated policies succeed. Because in India, health, social justice, and, these different ministry come together and we really need to run for one after another. Disability is looked after by something, medical college are looked after by medical education, health is looked after by health ministry, and coordination between them, sometimes you lose all your hairs and yet nothing comes out. So we really need to work into that health, social welfare, education, labor come under one thing, and something at a political level can be done to have all this under one umbrella. There are Asian Oceanian collaboration with shared vision for regional excellence, and this is what we will look at. Share the training platforms, we will do that, joint certification, research networks, and standardizing guidelines. So existing collaboration, what we are doing, IFNR with AOSNR, with WFNR, WFN, AON, partnerships are already active, and the WFN AOAN e-learning program is enabling cross-border knowledge. Similarly, we are doing is ISPRM, and AIPMR, and you will see that today we are going to sign a MOU between AIPMR, IFNR, and ICMR to take it neurorehabilitation forward in at least in India for the future. So that's something which we have been able to do that. So what is the roadmap for the future? From intent to impact, we have short term, that is 1 to 2 year planning. We target about 500 plus professional trained. Then we have years, that is 3 to 5 years is midterm, which is very, very important because we need to have scale successful training models, integrate rehab services, establish AOSNR regional training hubs, and we target about 5,000 plus professional to be trained in this region. And then, of course, long term, where we target measurable reduction in rehabilitation access gap. So this is what we are going to work in next 10 years time. So what is the call to action? Our collaborative responsibility for the clinicians, for policymakers, for academics, and the professional bodies. And here I also want to add the NGOs. And you will see that on Sunday, we have invited 12 NGOs representing most neurodisabilities like TBI, spinal cord injury, the MS, Parkinson's, stroke, epilepsy, cerebral palsy, and they all will come together to put together their issues and take it back to the policymakers and the professional bodies to represent at a national level. So what rehabilitation is not an adjunct, it is an essential care. Every patient who survives a stroke, lives with epilepsy, or faces neurological disability deserve the chance to recover, participate, and contribute. This is what we should understand. And LMIC across Asia and Oceania, and we have the knowledge, the evidence-based models, and collective will. What we need now is collective, sustained, and urgent will to take it forward. So let us build a future where neurorehabilitation competency is not a privilege of geography or wealth, but a universal right. And this is the paper which made a landmark difference, published in Frontiers in Neurology, original research, education, training, and practice of neurorehab in India during the COVID-19 pandemic. And this was something came out is pandemic disruption, of course, practical skill deficiency is there. There's a reduced clinical exposure, and this is not me. 5,000 rehab specialists across the region has gave us digital resource gaps and embracing hybrid model. And on this model, we created a platform for training across the Asia Oceanian region. The recent publication in a collaboration with AOPMR, what we have, advancing physical and rehab medicine education and research in Asian Oceanian region, the Ferry Khan and Bhaskar, we collaborated a positional statement for establishing the Asian Oceanian academic network of physical and rehabilitation medicine. And we are working on this, that how we can, and we have actually now implementing this in India through the collaboration between, and Dr. R.K. Srivastava, our former DG and the patron of IFNR, has been instrumental in getting this MOU between AIPMR and the ICMR. So strengthening the PRM education standard, key priority for Asian Oceanian is standardize the curricula, regional collaboration, research capacity, and structure program. This is another one, National Commission for Allied and Healthcare Professional. And when Achima wrote to me that she is writing this, she wanted IFNR to write sort of a recommendation for including the cognitive neurorehabilitation and the rehabilitation. IFNR wrote, and there is a clear-cut framework has been published now in the lesson. I think it will come. So it's standardized and competency-based is something which framework is required, mandatory clinical training, multidisciplinary team care, evidence research and ethics, and care progression and CPD. So these all will be taken care in the future. I want to thank you as a president of AOSNR Oration in today to tell you that the Oration draws on the collective scholarship, advocacy, and clinical dedication of neurorehab professionals across Asia and Oceania who are present here, working daily against extraordinary odds to restore the function, dignity, and hope to those who need it the most. And key references are WHO Global Status Report on Neurology, Lancet Neurology, Value in Health Cost Effectiveness of Home-Based Rehab, WHO Rehab 2030, and WHO Rehab Competency Framework. And there's more coming, and you have the WCNR 2024, 2026 in October. You are most welcome there. And Noryati is organizing the 7th Oceanian Congress for Neurorehab 2027 at Malaysia. So you have the opportunity to be there. Thank you very much for all your attention. And I hope I have stimulated enough to come together, all multidisciplinary, to take the neurorehabilitation, what people with neurodisability deserves, not as a sympathy, but as their right. Thank you very much. Namaste.
Dr. Nirmal, it is really an honor for us to chair this presidential oration for AOSNR. As everyone in the hall know, you are considered like the titan in the field, in neuro rehab, as you are able to bridge the gap between high-level scientific evidence-based practice, and also you go to the grassroots and see how best to actually advocate for neuro rehab in the state and also the region as well. We do have questions on our way as chairs before we open to the floor.
Normally, Oration do not have the questions.
So, but would you be able to, from your expertise, would that be possible for a question from the chair?
You are most welcome. Thank you. Yeah.
May I?
Yeah.
I'm especially very interested in the when you mentioned that there is the good governmental support in India. So maybe for the benefit of everyone here as well, including myself, what would be the best compelling argument to present the policymakers to prove that your rehab and the competency training really make a difference in the state, nation,
So what we really, I know there is a lot of interest now for people to take the training in neurorehabilitation, but they don't know where to go. They don't know which institute they should go for the training. There's no uniformity in the training program because there are institutions which are oriented by physical medical rehabilitation, which are not completely neurorehabilitation. There are no institution in neurorehabilitation which is giving a program. And that is the reason when Dr. R.K. Srivastava has been trying for the last 1 decade to get the physical medical rehabilitation and the neurorehabilitation to come together to develop a program which is apt for the young people who wants to do the neurorehabilitation, whether it is from neurology, neurosurgery, physical medical rehabilitation, or physio, OT, ST. And in that direction, I think it is very important because there are proper program in UK, in US, in Korea also, but not in other LMIC. And we really need to have a uniform program in the LMIC countries where the people can go there, get it trained by not paying huge amount of fees. Uh, Guhan has gone to Singapore and did the fellowship in neurorehabilitation for 6 months, but it cost. Everybody cannot afford to go to a country like Singapore. So if we can create that at 1/5 cost or 1/10 cost, what they have to pay in Singapore to India, it will be much better because India now has got a lot of education experts in all the field, and this is a place where we can provide low cost training even from any country neighboring or from the Asia. What we have done is, as a professor in neurorehabilitation, probably first professor in this country in Pacific Medical College at Udaipur, we have started a fellowship now for the physiotherapists, speech therapists, and occupational therapists for 1 year, which gives them, which under the umbrella of IFNR, to give a uniform post training. I also got requests from a couple of other universities, the two people who are sitting here, Dr. Yadav and Dr. Damija, who has also requested us to have that uniform curriculum to be applied for the fellowship in their IBAS and his medical college to give a uniform program. So IFNR will develop a competence training program for the neuro rehab specialists, specifically for the therapists as well as for the neurologist, neurosurgeon, and PMR. And I think this is going to change the way neurorehabilitation is being trained and treated and services being provided in coming next 5 to 10 years. And I'm sure this will change the way we have been practicing because there are a lot of advancement. And then this will also draw, we'll be able to get trainees not only from India, but also from other part of the world. So that is what we've been looking at. Thank you. Thank you very much.
Thank you very much, Dr. Nirmal. So you know, in my opinion, you have given us a very good perspective, a very personal perspective as well, very masterful and well delivered, and provides a scalable blueprint not just for India but also the region and beyond as well. So we would give you the pleasure of giving the best hands clap for Dr. Nirmal Surya for the very excellent and very thoughtful and thought-provoking oration session. Thank you very much, sir. It has been a really great honor for us both to be the chair for this session.
Thank you all.